Alrighty then. So now we're going to talk about care of patients with inflammatory intestinal disorders. And we're not going to really talk about malnutrition. That is in chapter 60, and we are not covering chapter 60. Again, we are not covering chapter 60. I just was trying to not redo the whole slideshow because people don't like it when I do that. But we are just covering chapter 57. We are not covering chapter 60. So our objectives are to differentiate between the common types of acute inflammatory bowel disorders, to compare and contrast the clinical manifestations of ulcerative colitis and Crohn's disease, to, to identify priority problems for patients with ulcerative colitis, to explain the purpose of and nursing implications related to drug therapy for irritable bowel disease, plan evidence-based postoperative care for patients undergoing surgery, and explain the role of nutrition therapy in managing the patients with diverticular disease. So we're going to start out with peritonitis. And peritonitis may very well be covered again next semester. And we're not going to talk about it as far as it going on into septicemia, but I do want to give just a brief overview of peritonitis because a lot of times patients will not have peritonitis when they are originally in the hospital, and they will develop peritonitis because of a change in whether it's from the inflammation becoming more acute or the infection becoming more severe. Peritonitis is most often caused by a contamination of the peritoneal cavity by bacteria or chemicals. Bacteria can gain entry from a perforation in the peritoneal cavity. Nursing interventions include assessment of vital signs, reporting changes such as hypotension, tachycardia, fever, changes in skin color, or whether the skin has become very dry, and or if the patient has tachypnea. Also, if they have mental changes, such as confusion or a change in their level of consciousness. All of these can be signs of sepsis and would be a reason to give the provider a call. When you're dealing with a patient with peritonitis, you want to practice frequent hand hygiene. You want to make sure that you're keeping their O2 saturation greater than 93%, unless it's contraindicated because of underlying pulmonary disease. We will restore fluid and volume balance using hypertonic IV fluids and broad spectrum antibiotics. We're going to look for fluid shifts that conform from the extracellular compartment into the peritoneal cavity, connective tissue, and GI tract. This is called third spacing. Again, this is when fluid shifts from the extracellular compartment into the peritoneal cavity, connective tissue, and GI tract. It's called third spacing. So the patient will look very swollen, but they are hemodynamically dry. So they will have, this can cause a significant decrease in circulatory volume and can cause hypovolemic shock. These patients are usually very swollen. Other reasons that can be causing hypovolemia is because of NG suctioning. They are also MPO. All of these are reasons that you want to keep up with an accurate INO so that you can tell is the patient having enough urine output. Remember, everyone should have at least 30 milliliters of urine output an hour. And anything less than that, you want to make sure you let the provider know. These hospitalizations can be very long, and because of the long hospitalizations, especially if they've had a really bad infection with their peritonitis, they may need rehab. You want to make sure that you're teaching both the patient and their loved ones signs of infection, signs of ileus, and signs of wound dehiscence. Peritonitis is sometimes called a hot belly. These patients, again, you'll see Risk factors for it include abdominal surgery. They will sometimes have it with an ectopic pregnancy. Perforations can be from trauma. It can be an ulcer. It can be from a ruptured appendix. It can be from a ruptured diverticulum. Nursing care is IVs and electrolyte balance. You want to manage the GI distension with their NG tube. You want to prevent complications such as immobility. You want to make sure that you keep up with good pulmonary hygiene and try to maintain their fluid balance as well. Okay, speaking of that ruptured appendix, we're going to talk about appendicitis. Appendicitis is an acute inflammation of the vermiform appendix. The inflammation of the appendix occurs when the opening to the lumen is obstructed, leading to infection as bacteria invade the walls of the appendix. Okay? Gangrene and sepsis can occur within 24 to 36 hours and are life-threatening and can be the cause for emergency surgery. A perforation of the appendix can cause peritonitis, and you will see an increased temp greater than 101 and an increased heart rate. Nursing interventions is pain assessment. You want to look for abdominal pain that increases with a cough or movement and is relieved by bending the right hip or knees, suggesting perforation or peritonitis caused from the appendix. And a lot of times when these patients present to the emergency department and they already have peritonitis or a perforation, they are almost in a fetal position with those knees very close to the chest, or up above the abdomen, and you ask them to straighten their legs out, and they're like, no, I can't, it hurts too bad. So that's kind of a telltale sign as well. Make sure that the postoperative care for these patients is routine post-op care. There's nothing special that you need to look for as far as that goes as well. They will have rebound tenderness at McBurney's point. It doesn't say in the book that you shouldn't do that, but if you are concerned that it could be perforated, you never want to push on it. I personally wouldn't do it. I just think that needs to be an advanced practice move. As far as, but you need to know where it is. The Burney's point is where you can find they'll have rebound tenderness for appendicitis. But as I said, I personally am not pushing on it because I don't want to be the reason it ruptured, and somebody with a higher pay grade than me can do that. That is the G. Marie humble opinion on that. Okay. So chronic inflammatory bowel disease can be both ulcerative colitis or Crohn's disease. It's individualized management of the disease, and there are differentiating features of ulcerative colitis and Crohn's disease. And I want to make sure that you look at the page 1150, and that table 57-2 goes over the differences very well of ulcerative colitis and Crohn's disease. So assessment for ulcerative colitis, you want to make sure that you look at their family history, nutrition, their history of bowel elimination, what medications they're taking, abdominal pain. You see there the diagnostics. Interventions can be emotional and physical rest, skin care, and they need to make sure that they're weighing weekly. Medications that can be used include, for the anti-inflammatory effect is usually for maintenance. Glucocorticoids for exacerbations. You'll see antidiarrheals to manage symptoms, and immunomodulators to autoimmune response, and they work well with steroids as well. Ulcerative colitis is widespread inflammation of mainly the rectum and rectosigmoid colon. It is associated with periodic remissions and exacerbations, including intestinal infections. Psychosocial assessment they can have the inability to control the disease symptoms, particularly the diarrhea, and it can be disruptive and anxiety producing. A lot of times these patients have a lot of anxiety and feel like they're being tied to the toilet, that they're unable to lead a normal life because of the uncontrollable diarrhea and the fecal incontinence that they can have with this diarrhea. Ulcerative colitis continued. Nutrition, you want to identify the foods that can cause flare-ups. You want to avoid GI stimulants. You want to make sure that they're resting during exacerbations to decrease intestinal activity. Sometimes these patients will have an ileostomy. And remember that these patients need to have, one of the core measures from JCAHO is that they have to have their antibiotic 1 hour before incision time. Interventions postoperatively are pain control, pulmonary toilet, that cough turning, deep breathe, skin care, nutrition, monitor for GI bleeding. And this is all listed for you quite nicely on page 1156. For the non-surgical management of these patients, nursing interventions include decreasing the diarrhea. A major concern with these patients is the frequent bloody diarrhea and fecal incontinence. I spoke about that when I was talking about the psychosocial aspects of it. Non-surgical management includes nutrition therapy and physical and emotional rest. And then usually the surgical is the ileostomy. And with the ileostomy being more acidic, you do have to be more cautious with care of the skin around the stoma, even more so than you do with a colostomy, because you have to think of where the ileostomy is. It has more acid, and so it can be more damaging to the skin. Crohn's disease is a chronic inflammatory disease of the small intestine. Most often, but it can be the colon or both. Inflammation causes a thickening to the bowel wall, and strictures and deep ulcerations that cause like a cobblestoning effect, puts the patient at risk for bowel fistulas. Again, make sure that you look at table 57-2 to differentiate between ulcerative colitis and Crohn's disease. Assessment can be assessment. You want to make sure that when they have an exacerbation, it can be, Crohn's disease can be exacerbated by a bacterial infection, and signs vary greatly from person to person. Interventions are similar to the non-surgical care of ulcerative colitis patients. Medications are similar. Glucocorticoids are only used short term because they can mask an infection, which can lead to sepsis. In addition, they usually will add Flagyl or Letrozole to help with managing the fistulas, to help with the infection with the fistulas. Poor nutrition can lead to inadequate fistula and wound healing, and loss of lean muscle mass, decreased immune response, and increase mortality and morbidity. Again, make sure you look at that table that talks about the complications of both ulcerative colitis and Crohn's disease on page 1151. Also, you want to make sure that you look at chart 57-5 on 1158, which discusses home care for patients with both ulcerative colitis and Crohn's disease.